Thank you all for being here. Today's program, we're really delighted that ASHK Society Hong Kong can host Dean Megan Ranney, Dean of Yale School of Public Health, for a discussion on something that we are all very interested still, well, even more so after what we went through this last 4 years, future of public health and digital tools and effective communication. And it's going to be a very, I know it's going to be a very interesting topic because of her really extensive background in this area. And we are really delighted that Dean Ranney is here at ASHK Society Hong Kong. And those of you who know that during COVID, we had, a series that I started a few weeks after COVID first hit Hong Kong. Oh, first we heard of it. And it was February 14th, 2020, that I started a series looking, COVID updates. And by the time we were done, I had done 46 episodes. And I was so happy to say goodbye to that, but I learned a lot. Basically, it was an opportunity for me to ask stupid questions about COVID as it was developing day to day or week to week from experts, not just local. Originally, it was local experts. We have a lot of friends from Hong Kong U here, and it started with Professor Ben Cowling. But in the end, we were able to talk to experts from all over the world on this topic. And I think it still is something that all of us are still interested in. I'm particularly in the area of public health. We're going to have a program. Those of you who have not had an opportunity to sign up, and the program was announced just, I think, last week or this week. We are going to show a documentary called 2020, Chaos and Hope. And it's a wonderful documentary that documents 2020, what it was like in the United States. And I think some of Dean Ranney's colleague is interviewed in this documentary, Chaos and Hope, and we will have the producer, Cece Chen, with us for that program, and Professor Vivian Lin from Hong Kong U, who could not be with us today, will help us moderate that program. So I wanted to that will be on Monday, April 22nd in the afternoon, so mark that on your calendar. With that, I want to thank all of you for being here again. This is a calm before the storm. Next week, ASHK Society, when you came in, you could see that there's an exhibition being installed at the Jockey Club Hall, and we currently also have another show being installed in the Chantel Miller Gallery. Both shows should be opening this weekend. The Wilfredo Lam show, the Chantel Miller Gallery show, will be opening this Friday. So we look forward to seeing you here for the various exhibitions and the activities that will be going on during next week's Art Week. And I know I'll be seeing many of you. I know I'll be running into Max left and right because of his involvement in the arts field as well. So enjoy today's lunch, and I know around 1 o'clock, our good friend James Chau, president of China United States Exchange Foundation, and also a World Health Organization Goodwill ambassador. James is no stranger to ASHK Society and this topic. We've done several great programs here with Dr. Margaret Chen during COVID, and also other deans of public health in this room. So we're in very good hands with James moderating today's talk. And so with that, enjoy your lunch, and I look forward to seeing you all around town, and have a wonderful, wonderful day. Thank you.
Good afternoon, everybody, and thank you very much for being with us. I will jump straight in, given Alice's beautiful introduction to us. I'm James Chau, very, very happy to be sitting here with Dean Dr. Megan Ranney. I went to your Twitter, and it was the most succinct Twitter biography I've ever read. In 6 words, you tell us what you do. I fix problems and promote health. But I hope that you'll allow us to have a longer than 6-word conversation today. Dean Ranney, you are an emergency physician, a researcher, and a national advocate for innovative approaches to public health. And it was about this time last year, I think, when you were appointed the head of the School of Public Health at Yale, not merely succeeding who had come before you, but really it was the moment when the School of Public Health came into its own as well. But if you look at your professional career and more deeply and more broadly your life as a whole, what's been the defining experience? I mean, where were you born and where is home in that formative sense?
Absolutely. Thank you. Well, it is an absolute joy and privilege to be here at the ASHK Society today. As I've shared with some of you, this is my first international trip as dean, and it is a pleasure to make it here to Hong Kong and to get to have this conversation with you, James. So a little bit about me. I grew up in Buffalo, New York, so Western New York, relatively non-urban area of the world, also a politically divided part of the United States. So did not grow up kind of in the Northeast. We would consider ourselves Midwest to those who are from Ohio in the room. And grew up not really quite sure what I would do with my life. Went to Harvard as an undergraduate, where I majored in the history of science. So looking at how science and society interact. As we've all experienced over the course of COVID, the very best science in the world, the way that we interpret it, the way that we use it, is influenced by the culture and the society in which we live. From there, after undergraduate, I actually went to Peace Corps, and that's one of the two, I would say, really defining things in my life in terms of what I do today. I spent 2.5 years in West Africa, in a country called Côte d'Ivoire, or Ivory Coast, and was there at the height of the HIV/AIDS epidemic. I had studied as an undergraduate just the very beginnings of the response to AIDS, but I got to West Africa, where although antiretrovirals had been invented, they were not at all available to Africans, and saw friends, neighbors, colleagues decimated by this disease. And a large part of why HIV was taking the country by storm was because they had no reason to get tested, because they had no hope once they got a positive test. It was a death sentence. And so there was no reason to find out whether you had HIV or whether you had something else that was potentially life-threatening, because it would put you as a marked person, you would be isolated, and you knew that the end was nigh. I started working in West Africa to try to get folks access to antiretrovirals. There was a World Health Organization sponsored trial going on in Abidjan, which is the main commercial city and the kind of, for all intents and purposes, the capital, although the real capital is a different city. Tried to get friends to go down to Abidjan, which was an 8-hour bus drive, to get treated, and they wouldn't accept people because they were too rural, they weren't well enough educated. It was thought that they wouldn't be able to take the medications, and so they sent my friends home to die. And that was a defining experience for me in a couple of ways. The first was to see in stark relief the fact that, again, whether we do science or not, doesn't matter if we don't have ways to apply it. I had HIV tests that folks could take, but they literally would not take them because of that lack of hope. It imparted on me the importance of working on a community level to address the behavioral reasons, not just that the disease was being transmitted, but also the reasons that people wouldn't talk about it, and also imparted in me the importance of equity in the way that we approach public health and medicine. It was that experience that had me decide to go to medical school, and then from there fell in love with emergency medicine, which any of you who have spent time in the US know that the emergency department, or here A&E, is really the safety net of the American healthcare system. We don't have a public health system like you have here in Hong Kong. The emergency department is the only place that people can come to get care any hour of the day, any day of the year, regardless of their ability to pay. It is the only place in the American healthcare system where we are mandated to provide care to all. And so to me, it was an extension of that experience that I'd had in Peace Corps, trying to provide care, trying to provide opportunities, and through treatment and diagnosis, trying to motivate people to take better control of their own health. From there, long story, went on, kind of did my public health degree. I actually focused on injury prevention and violence prevention, partly because of the experiences I'd had in Peace Corps, where so much of the HIV transmission was related to gender-based violence. And that was then when I had the second really defining moment. I took care of endless victims of gun violence and of violence in general over the course of my training as an ER doc in the United States. But it was after I had finished my training, after I had done my public health degree, that I took care of a young man who really changed the trajectory of my career. We are eating, and not everyone in the room is in healthcare, so I will not be graphic, but just it was a young man who came in with a gunshot wound, which was not unusual in the United States. But instead of a wound that was inflicted by someone else, it actually turned out that he had shot himself. He died by suicide by firearm. And it was at that point the first time that I had seen a suicide by firearm in the United States. At that point in my career, James, I was told, just as I had been told in Peace Corps, that people won't talk about AIDS because it's something you can do nothing about. Similarly, this case, this young man who I took care of, affected me deeply, and I started asking questions about how common is suicide by firearm? Why do we not talk about gun deaths in the United States? And I got similar answers to what I had received in the Ivory Coast, talking about AIDS. Well, we don't talk about it because there's no funding. We don't talk about it because there's nothing we can do. We don't talk about it because there are, it's a third rail of American politics to talk about firearms. And I said, that's ridiculous. This is a health problem. I see people coming through my emergency department who are physically injured, and I see their friends and family who are emotionally injured. This is clearly a health problem. And so that case ended up switching the trajectory of my career and had me spend the next 15 years working to reestablish a public health approach to gun violence in the United States. Applying, again, those scientific tools, theories of behavior change, epidemiology, communication skills, health policy skills, to try to start to change that trajectory. We have not succeeded yet, of course, in the US, but to try to change the trajectory in a way that created space for everyone, the same way as I had done in the Ivory Coast. So I would say that those are probably the two biggest defining moments. COVID, of course, was a bit of a defining moment as well, but I'm sure we'll talk about that.
And you were linked very closely to the COVID experience, of course, through looking at related risk reductions during that time. But I want to go back to these defining experiences because they actually all link up. And I suppose the common denominator is people and communities. The first one where, as a student, you were a big part of this Peace Corps program, which I think was founded by Sergeant Shriver, wasn't it?
Correct. Sergeant Shriver under JFK.
And the brother-in-law of JFK, wasn't he? And then you go into HIV/AIDS epidemic during a very deep part of that curve in West Africa, because we often think about it as being something in sub-Saharan Africa, but of course it was all over the world, including all over Africa as well. And looking at the issues where stigma, discrimination, and absence of hope is the barrier to treatment, if treatment is even available, accessible, affordable. Then you're looking at gun crime and emergency care where you see the best and worst come through, in the sense that there is no universal health coverage, which is affordable quality health care, which most of the world doesn't have. It's not isolated to the United States, but it stands out in the United States because it is the world's leading economy. I suppose when you told me very kindly earlier that you'll be going back to the emergency room in the next months. Is there any evidence-based hope for people today when we know that there will be a next pandemic where you work through that? Evidence-based is an important add-on to the word hope because of all the triumphs of science around COVID, there's been an immense, immeasurable, and irreplaceable loss for millions of people and families and communities globally.
So I want to, the last statement that you made around the immeasurable loss, I think we haven't taken enough time as a society to really acknowledge that loss. I will say I'm a parent of two. I have a 15-year-old and a 12-year-old, and like many of us who have children, many of their formative years happened during COVID. My children's sense of the way that the world works is forever shifted from what mine was growing up. And to me, it was, 3 years, 3.5, it's now been 4. It was a blip in my life. For my youngest, for my 12-year-old, he was barely 8 when COVID started. And so his sense of what it is to be a child was shifted. So many of us have lost loved ones over the course of the last 4 years and haven't necessarily given ourselves time to process that grief or trauma. And then for healthcare workers, and I know you've spent time speaking with many healthcare workers across the globe, including Vanessa Carey, who's a friend and has done a lot of work on healthcare worker access globally. I think we haven't spent enough time processing the trauma of caring for COVID patients in the worst of the pandemic. Because of all of that lack of processing the loss that we've experienced, I think we've rushed to blame and to revisionism around what actually happened during the pandemic. So we've learned a lot of really important lessons that we can and should apply to what is inevitably going to happen again. I don't have to tell you this. You lived through the original SARS here in Hong Kong. In the United States, we, luckily, were not deeply affected by SARS-CoV-1. But you know that these viruses evolve, and it is almost inevitable that there will be another pandemic. I think we learned a lot of really important lessons during COVID around how to use technology to track and manage surges, around how to develop vaccines quickly and distribute them effectively. We learned a lot about the weakness of our supply chain and how to create global collaborations to help support and fill in for those weaknesses. My concern, though, is that because we never took that time to grieve, we also have not taken the time to cement those lessons and instead are rushing to try to pretend that we didn't learn them. So that's not necessarily a hopeful answer for you, but I think it's a realistic one, which is that we can't have hope if we don't take the time to, which is why I love the book that you wrote, if we don't take time to actually document what we learned and think deeply about how we can take the best of what we did and where we can improve upon it.
I know that you wouldn't say this, but on behalf of the community that you are, which is the HIV community, it was those people that had a big part in the jumpstart solutions we were able to quickly put in place for COVID.
Correct.
Both in the public health approaches, the science approaches, and particularly in working with civil society and bridging that to science and health and bridging that to political leadership. Now, HIV, everyone who's worked in HIV knows all the transformative outcomes that occur when you link civil society with science, with political leadership. And actually it's the civil society and the health that brings the political leadership, which is often very stubborn about coming in, as we saw again. We're here to talk about the future, and you've helped push forward and remold what the frontiers look like in digital health by developing, testing, and disseminating digital health interventions to prevent violence and related behavioral health problems. But technology, as we know, is ever-changing. What we say today may be a little outdated, perhaps, in a month or two, but especially with the rise of artificial intelligence. Is there a natural opportunity, not a low-hanging fruit, perhaps, but you see something, you say, well, that we haven't exploited that yet when we talk about health and healthcare systems?
I have a couple of different answers. The first is, when we talk about civil society, to me, that's where public health and civil society are deeply intertwined. And if I talk about technology, I think that we've lost the plot if we're talking purely around the development of new technology, new scientific tools, new ways of gathering or analyzing data. Those matter deeply, and I believe in, it's one of the reasons I'm a dean, I believe in that power of kind of basic science and original discovery. But discovery alone is not sufficient. Where we can make a difference with technology or with any new science is in that application. It is in that partnership with civil society. And to me, that's one of the fundamental characteristics of public health that makes it so powerful, is that we are not just about the basic discovery, but we're also about scaling those discoveries out, about having the relationships with educators, with business leaders, with political leaders to help create policy change, to help get technologies into private industry, or to think about ways to disseminate technologies through the non-governmental sector. So that's the first part of the answer around where I think technology is going. I think there's numerous things that have already been developed that already exist, that don't require further developments in generative AI or in LLMs. We've got stuff already. Many of you used it here in Hong Kong quite effectively during COVID to identify outbreaks based on Bluetooth proximity, to look at wastewater data, to kind of foresee when there was going to be a surge. To look at, in the United States, we could look at open table restaurant reservation data and preview that there was going to be an upcoming surge of COVID. We're using AI already to help monitor for emerging pathogens and biosecurity threats. These are not new technologies that need to be developed. They are there already. What we've lacked is the ability to put them into practice in a systemic way. And so if I go back to that Peace Corps experience, it's like having antiretrovirals which slow the growth of HIV and hold off the development of AIDS, and which may even prevent the transmission of HIV. Having those drugs but not using them. Today we have these technologies, but we're not putting them in place. And I think it's a couple of reasons. The first is that we have not facilitated I will say quite honestly, the profit motive behind much of the greatest health technology that's being developed. We haven't yet figured out how to make it profitable and sustainable. We rely a lot on the government, on it being a public good. In the United States, at least, that's not sufficient. We don't see sufficient public funding to help put the technology into use. And honestly, in the US, folks often don't trust the government. So it really has to be in collaboration with the private sector that will see the use of technology for good in health. The second reason that we're not seeing technology used as it could be is because of, in the US at least, privacy and security concerns. We were talking at lunch about some of the measures that you had in place here in Hong Kong during the outbreaks, things like having the Bluetooth on your phone when you went into a restaurant, right, to show that you'd been vaccinated and also to allow contact notification. We were unable to roll that out on a large scale in the United States because of folks' concerns about surveillance. And then the third thing that blocks us is that, honestly, our technology systems as a public sector have not kept up. So whether I'm looking at a university or at a hospital system, we were faxing COVID results to each other in the early days of the pandemic. We overcame that with government funding at the height of the pandemic, but as we've seen the funding dry up, many health departments are going back to, in the US, are going back to their kind of 1990s version of data tracking. And I think that's true globally as well. Unfortunately, we don't have the international partnerships and data sharing that would allow us to take full advantage of some of these great new technologies that are being developed for monitoring of disease, for forecasting of disease, and for facilitating behavior change and communicating what we know about disease.
I think that academic freedom, which is where you're from, journalistic freedom, and health are the three areas that need to be protected and kept sacred from the claws of politics.
Hear, hear.
Yeah. But the reality is that politics has set its claws in already, especially as we saw during COVID, but that's not the only example. AIDS was another example. With what's coming up in the States and the global impact that will have on everybody, including everyone here in this room, do you foresee that your ability to work, discover, and apply those discoveries will necessarily change if either of those two candidates get through the winning post?
It's a great question. Who knows what's going to happen in the United States in November and beyond. I am nonetheless quite hopeful that places like Yale will continue to hold our tradition of academic freedom and discovery sacred. I mean, it's our motto as a university, Lux et Veritas, truth and, light and truth. That's what we've stood for over 300 years through a lot of ups and downs in society. And I'll frequently say to folks that actually one of the reasons that I took the deanship rather than other opportunities that were outside of academia is because I believe so strongly in that function of the university, especially in moments like today, which are turbulent and uncertain. Nonetheless, we as faculty have a duty to discover and to share those discoveries with the world. We also have a duty to educate that next generation, to develop skills themselves, and then to bring those skills forward in leadership. And I don't see that changing, regardless of who is elected. I feel very privileged to be at a place like Yale, where no matter who's in office, we will be there, and we will continue to educate, and we will continue to do research, and we will continue to partner to help translate those discoveries out into the world. Now, there are certainly things that could shift in the United States or globally that make it easier or tougher to meet that mission. But I mean, if I look at Europe, if I go back, hundreds of years, again, if I use my history of science hat, universities in Europe kept doing great work. It was universities and religious institutions to some degree that helped keep science moving forwards, even in the worst of the Dark Ages. I don't think we're headed for something that bad, but I do believe deeply that we'll keep doing our work and keep creating a path for a better society, no matter what happens with elections in the US or elsewhere.
I was going to ask you, what are the areas that could really leverage the spirit of international collaboration? But I think let's look at the US-China angle, because we are here in Hong Kong, and we see Hong Kong as a great new contemporary gathering point for the US-China relationship. At our foundation, we're about to make an investment in neglected tropical diseases at the Carter Center, our longtime partner, because President Carter had told us, a couple of years ago, that the United States and China should work together, but not on each other, because there's a complete breakdown in trust. Instead, what they should do is they should apply that power that they have and put it towards a third region. Now, he was always going to be talking about Africa, because that's his love for the people of Africa. So that's part of the reason why we're going in that direction. More broadly, we've seen the United States and China work very effectively since the San Francisco Vision was established in November between the two presidents, especially on fentanyl. Now, this is a very, very sensitive topic for China, because they didn't want to be blamed for this public health crisis in the United States. And I would say, rightly so to some extent. But some of the raw ingredients are coming, I think, from China, from Mexico. And there's somebody, as a diplomat, an American diplomat, said the other day, not from the government of China, not from the companies in China, they're just from some illegal setups. Now, since November, they've made real progress on this front, and we hopefully will see that progress spill out, in the sense that people wouldn't be living on the streets, wouldn't be isolated and off the margins of society in America. But fentanyl or otherwise, what do you see as the great collaborative opportunity that people like us should be working on? What's your advice?
So I have a deep bias, so none of you will be surprised to say that I actually think that working together on health is one of the spaces where collaboration not only will, but also must continue. Folks will often say to me, "Oh, your School of Public Health, do you have a global focus?" I say, it would be impossible not to have a global focus at a School of Public Health, because all public health in this day and age is global. Between climate change, mass migration, airplanes, social media, there is nothing that knows national boundaries when it comes to health right now. And in addition, it is the one space where you can get governments to understand that what happens in one country affects another, and that collaboration behooves the stability of both. So to me, health in general is a space of tremendous potential collaboration. Our school, actually almost 50% of our students at the Yale School of Public Health are international, non-US born. And of those, the majority are from Hong Kong, mainland China, Singapore, and surrounding areas. So we have a tremendous and long, strong historical as well as current relationship with not just Hong Kong, but also with mainland China, based off of our shared appreciation of the fact that we are all human, and that determinants of our health, as well as interventions that can improve our health, need to be developed cross-nationally. My chair of biostatistics, Shuangge Ma, is actually he couldn't make it today, but it turns out he's actually here in Hong Kong right now. He's a biostatistician who looks at the genomics of cancer and is here because of his longstanding partnerships with folks at various universities across Hong Kong to try to extend those, to expand on those partnerships, and to expand on our ability to exchange data in order to improve the health of all. So to me, this is a space where it's a no-brainer in terms of international collaboration, and where each of you, being in this room, presumably have an interest in health, but can help make a difference in terms of facilitating those collaborations and shared quest for improved knowledge.
And I think Yale had an early history in mainland China as well.
That's correct.
Right.
I mean, it goes back to the 1800s.
Two very quick questions before we take some questions from our audience here. Can you give me one issue within health that you see as being possible that you would say, grab that? And secondly, since we have this captive audience, what is the call for action that you have with an influential, they're sold on the message. If they weren't before coming in, the food definitely did it, you did it. So there's those two parts. So is there a specific area within health, one issue? And then what's the call to action to everyone here in the room? Then we'll take some questions.
So the specific area within health that I think that deserves all of our attention is the effect of climate on health, which is about climate change, but also around the influence of the environment, chemicals, other wildfire smoke, but also environmental stressors. It is a space where there is a lot of emerging knowledge, but a lot of really important work to be done. And so to me, that's something that is absolutely, we can grab it, we can address it, we can do it regardless of politics, and there's a real imperative for our doing so, particularly if we talk about climate change and its already emerging impact on human health, as well as on our healthcare systems. We must address it or we're gonna be in trouble. In terms of what my ask would be of all of you, it would be to keep talking about the importance of health and public health as not just part of medicine, but as something that also enables a healthier healthcare system. In conversations with many of you over the last few days here in Hong Kong, as well as the work that I was aware of and kind of the readings that I've been doing for decades, I know that you, like the United States, are facing a system of increasing healthcare costs, increasing burden of an aging population. We can't fix that simply by training more healthcare providers or sinking more money into our healthcare system. We need to invest in our public health system to help keep people healthier, to deliver care outside of the walls of our hospitals, to improve physical as well as social health. And so the thing that you can do is to be a steady drumbeat for that importance of not just studying, but also acting to improve health and well-being on a societal level. We're not just about diagnosing and treating disease, we're about creating the conditions in which people can live their healthiest possible life, which then of course facilitates a great economy. And I think that you can be voices for that here in Hong Kong as well as internationally.
I will always take away from this conversation two words: peace, where you began with, and equity, which is what we're all trying to achieve together. Let's go now to the floor and see what questions we have from everybody here. We've got a question over here. I can do it.
Alfred Ho from City University of Hong Kong. I'm from social sciences side, and so you mentioned a lot about non-medical factors influencing health, and so I have two questions. One is how you do at Yale or maybe beyond to encourage more interdisciplinary research to really look into the social determinants of health issues and share some experience with us and give us some insights, number one. Number two is going back to your earlier question and some comments about the government can't do everything. And so in the US also, and I know that actually a lot of the data are actually not in the government hands, are in the big eight, like Google, etc. So if we ask you to envision an ideal model, how do you get the private sector to surrender, give out more data to encourage more intersectoral collaboration?
I love that. So it's funny. I am appointed in health policy and management at the Yale School of Public Health, but when I was at Brown, where I was deputy dean before coming to Yale, I was actually in behavioral and social science. My work bridges those boundaries quite intentionally. And I think if I go back to my comments about the history of science, we cannot consider science without considering societal influences. It is, to me, essential, and not just for a school of public health, but also for our creation of health in the larger world. I will say one of the things that attracted me to Yale was the interdisciplinarity of our university, as opposed to other well-known universities that I won't name that we may compete with, who are a little bit further north in the United States than we are. We are actually a very de-siloed university. I have joint degree programs with the School of Management, with the law school, I have courses that are taught with the School of Architecture and with the School of Art. Those, I think, are essential for public health because, again, we don't exist in a vacuum. We are part of a larger societal influence on health, and we cannot hope to improve health if we are not also talking about changing norms and changing the structures in which we live. If I go back to your question about environmental, my one thing that I think we could grab onto, that environmental impact, part of that is society. So that was your question one. And then question two was?
Intersectoral collaboration, especially private data.
Oh, the private data. Oh, I love that one. So I actually spent, in October, I spent 2 days out in Palo Alto and San Francisco. All of the deans and provosts at Yale, actually, we spent a few days meeting with many of the leaders of DeepMind, OpenAI, et cetera. So creating relationships. There's a real struggle because for private industry, the data is in many ways their greatest IP, right? It is the thing that provides value. It is their ability to use it, analyze it, create new algorithms. That is their entire business model. And the same thing is true for healthcare, increasingly. Healthcare systems see their data as perhaps they're having their greatest monetary value as well as kind of intellectual property. I think it's a space where academia can help create a neutral ground for sharing and looking at data in ways that improve health. I'm quite proud to have collaborated with YouTube, with Google, and with others, and I did a lot of work with Twitter back when it was Twitter. Not as much now, but that it's X. Looking at how we can actually use that data to improve health, to improve messaging around health behavior change, and to inspire community to act on behalf of health. I think it's about coming up with the right incentives for companies to collaborate. And again, I think the neutral ground of academia can be that space.
I don't think you've tweeted since December 2022. Am I right?
No, so I will actually say October 7th of 2023 is the last time that I tweeted.
Was it? Okay.
So.
Right. Okay, so other questions here? Great.
Hi, Dr. Ranney. Thanks for coming to Hong Kong. Welcome to Hong Kong.
Thank you.
That's a great sharing session and fireside chat. I think you made a very good point about the importance of academic freedom and freedom of speech, which is a very core and fundamental part of this, not just academic development progress in humankind, but also fundamental to the Western civilization as well. The challenge is, and I going back to the topic today, which is digital tool and effective communication, which I think is very important, is the digital tool that we have, such as social media, is also a big amplifier of problems that we have and misconceptions. And now, in the context of public health, is life and death issue. For example, I mean, vaccination has been declining because of a long retracted article in Lancet that caused suspicion on health issue and implications. And I'm just wondering to hear your perspective of how do we strike the balance between censorship and freedom of speech, because it is a very important part from the public health perspective.
It's a great question, and I will start by saying I don't have a perfect answer yet. We're actually investing in creating new scholarship around communication at the Yale School of Public Health, as well as training our students. There is a famous phrase about flooding the zone that was used by someone who I don't agree with politically, around flooding the zone with bad information. And I think that we need to flood the zone with good information. I think censorship is not just not a good path to go down, but also impossible. If you look at challenges for social media companies around monitoring much worse things than health misinformation, pictures of violence, incitements for riots and for violence, the sharing of really kind of graphic, harmful images. They have a very difficult time doing that. And those are much more easily defined as being wrong and not being appropriate for social media platforms than health misinformation, where there's always going to be some debate and some back and forth about science. That's how science works. So it becomes much more difficult to say this is wrong, this is right. I think our incentive system has gotten messed up, and so the ability for people like us in the room to share good information on social media has decreased because we're afraid of trolls. I also think our governments have not been up to the task of sharing information rapidly and in comprehensible ways. I actually think this is a space where technology can help us as much as it can hurt us in terms of generating culturally competent or linguistically appropriate messaging and then sharing it with community organizations or community-based trusted messengers who can then disseminate. I'm going to give you an example because that's a lot of kind of gobbledygook and academic talk. During COVID, I was part of a collaboration with the Rockefeller Foundation where we worked with communities in core cities across the United States, socioeconomically challenged, diverse communities, to try to change their communication and messaging around vaccines. We thought that what we were going to do was to hand them some messages and they would post it on social media and we would fix the problem. It turns out that what we actually had to do was spend a lot of time with the leaders of the communities to change their belief systems, and then they were able to go out and share these messages on social media. So I think the project is bigger than just saying we're gonna stop misinformation. It's really about kind of taking a step back, doing core education, and then providing tools to folks to allow them to share appropriate messages more easily. And again, to flood the zone with what's trustworthy as opposed to what's not.
Which is what they did during Ebola.
Correct.
The original Ebola, then the massive outbreak that started in 2014, where they went to community leaders who had that trust, faith leaders often. They took up megaphones and put them on top of vans, and it was some very, very basic, non-high-tech interventions, which were still technology. I think also in AIDS, it was short text messaging. You know, we don't SMS here in Hong Kong.
Oh, really?
It's only Americans who do this, right?
What is it all WhatsApp?
WeChat,
Yeah.
you know, but you guys use SMS.
Yeah.
But SMS was, you know, the huge mover for AIDS in Africa during the days where, not long ago, like 2010, 2011, where you could buy a basic burner phone
That's
and
right.
everybody could afford that. You
So
know,
it's
yeah.
actually how I got my start in digital health. I was working in Kenya at the point when they were doing some of the very first trials around text messaging for getting people to take their medications. And it was unbelievably effective. So brought it back to the US, a great example of how, but it needs tech. It also needs the real touch. I don't think you can ever take humans completely out of the loop. And the Ebola example that you cite, it was the imams and other religious leaders, but it was also showing up and helping to bury people and to provide some sense of humanity. It's that combination, and I think a lot of the vaccine, it's a creating trust in the system in addition to facilitating communication by the folks who are already trusted.
I remember asking someone from UNAIDS, I said, do you share your beliefs and values with some of these faith leaders that you reach out to? And he said, at this point, I don't really care. Yeah. It's what saves lives and who can be that messenger to saving lives that's really important for me right now. And just want to add on one thing about, in terms of communications, about how do you leverage the best of that, but also not let it turn into misinformation. I mean, Kofi Annan always used to say before he died that, you know, the power is actually within the individual, because we are the consumers. We spend, and ultimately, whether you're talking about X or Facebook or this or that, a lot of it comes down to advertising, a lot of it comes down to income generation. It's not as sophisticated as we all believe it is, yet it is a very sophisticated machine that moves all of this. So the individual clubbing together with other individuals, that power of the collective is quite extraordinary.
The power of the collective is tremendous. And that is where I think social media has great potential. I think we started a hashtag, gosh, almost exactly 4 years ago, Get Us PPE, that turned into a nonprofit that ended up providing tens of millions of pieces of donated personal protective equipment to healthcare workers across the United States. It was an unbelievably powerful example of that power of the collective. And we actually studied it and saw that folks that use the hashtag #GetUsPPE versus folks that use the hashtag COVID-19, when you looked at the sentiment in the tweets using those two hashtags, the hashtags using #GetUsPPE were more positive, hopeful, action-oriented, and community, had kind of characteristics of community baked into the type of messaging as compared to those with COVID-19. So it not just created a movement, it also gave people kind of psychological hope and agency, which I think, again, especially in this moment, is so deeply needed.
Are there any other questions? I think we've got time for one more. Simon.
Hi, Dean Ranney. So good to have you. Very proud to have you as our dean. I'm a proud Yale School of Public Health alum. And I'm, in this whole thing about public health education, outreach, all these years I realized that at the end of the day, being able to really, really connect and get the messages across, get people to actually react, get people to care, is always a continuous challenge. COVID definitely, in a way you can say the silver lining is that it really raised awareness across all sectors, people, societies, and so forth. But the thing is, like, moving forward, I'd like to hear your views in terms of, from an educator, from an advocate, where do we go? How do we actually get more influencers or different sectors to actually drive some of the solution, to make it happen? Even healthcare users. I mean, people talk about it all the time, but at the end of the day, when they go back to their work, when they go back to their daily lives, how can we raise the awareness more that it becomes more relevant? How can we actually get solutions that we talk about in big picture, get it more down to the level that there is more private sector interest, business leaders, because at the end of the day, they're people, like, they have tremendous influence over their people to act on it.
Yeah.
So that's,
So I
you.
think here too, it is this network effect. I think it all starts with the power of one-on-one conversations, either in person or virtually, and then it spreads. Any great idea starts with one person having a conversation with another person and then bringing more folks on board with them. If I go back to my early training in behavioral science, it's the idea of the teachable moment. You have a crisis, it provides a teachable moment, you enroll someone in creating change, and then they enroll others. And so to me, this is also the power of a group like the Asia Society, is that each of you can serve as that agent in your own network for enrolling others in the possibility of creating change. It is never easy, it never happens overnight, right? The stories get told and it's like, look, somebody flipped a switch and, oh, mRNA vaccines developed. Well, no, there was actually 15 years worth of research before them, right? We've brought HIV/AIDS deaths down by 90%. Well, we've had almost 3 decades of work in PEPFAR and other international collaborations to help create that. And similarly here, I would say that although one can take a very dark picture of where we are right now, there's also a hopeful one, which is that we each have that power to enroll others in creating change to facilitate health. And we have lots of examples. I'm sure each of us in the room have an example of a space where we've seen that happen, but it requires persistence and the ability to bring others along with us.
Well, there are about 30 influentials in the room, so this is a really nice network to begin with. And, looking back to AIDS, it also required, unfortunately, 33 million lives to expire before we got to this point. It's the greatest epidemic in modern history. Dean Dr. Megan Ranney, it's such a pleasure to have you with us. And as many people have expressed, thank you for coming to Hong Kong. I think there couldn't be a better time than today for you to be here. And an immense thanks to President Alice Mong for having us with us. Would you like to say some closing words?
Thank you both. You've really kind of added hope. I think. Thank you. And in fact, the program, the COVID update that I talked about, was really inspired by SARS and David Ho, Dr. David Ho, who's a dear friend. It was at a conference. We were talking about Committee 100 in 2003 that we had standing room only because a lot of people could not come to Asia for that conference, and we ended up doing the program at the Waldorf. So, you know, the network effect, and it, you know, we all have that power. So in some ways, thank you both, and we welcome you back anytime, Dean Ranney, and thank you, James, always, and I think thank you all for being here. Times like this, I think, it just made me really proud. I think Asia Society, our mission of Asia Society is more important than ever. And I thank you all for your support. And, you know, James, we look forward to future collaboration. And any, you know, program ideas, we always love to have them. And so please share them. I know many of you are involved with universities. Hong Kong U, we work with other universities here in Hong Kong. So please contact us if you have any interesting program idea. We always love to consider them. So thank you both, and have a wonderful afternoon.
Thank you.